Hello, hi, this is Ahmed Ghouri. I hope everybody's having a great day. It's a great pleasure to be here. I wanted to talk, and I know we have a lot of speakers, so I'll try to move quickly. I wanted to talk a little bit about what I think are important questions in actually operationalizing a learning health system. The key questions that need to be asked, and I believe that we're not going to try to answer these questions today, but I wanted to lay a framework of what questions should be asked so that you can lay out an operational plan. I've previously founded a healthcare analytics company that was able to obtain data from multiple disparate stakeholders that normally would not share data, competing insurers, competing hospitals, personal health records systems, competing laboratories. So I previously developed kind of an intel inside that powered multiple competitors, right? And I found ways to make them, give data to a central organization because they could derive value from giving that data. And so, in my opinion, there's two ways to create a learning health system. One is in the private sector, which I'm currently doing with my new company, Interpreta, and one is in the public sector, which can be done independently and in parallel. And if you think about the human genome, it was simultaneously sequenced by both the private sector and the public sector at the same time. And there was actually a competition and a race that was beneficial to make this happen. And I think we could do the same thing with a learning health system. So what I wanted to talk about in operationalization is, how do you define that, right? And to me, that's the process or steps taken to deploy an abstract concept, whether it's a satellite or a lunar lander or whatever, in terms of observable, measurable characteristics that include the identification of who's going to lead it, who's going to be accountable for which milestones, and what's the time frame for each milestone. So this is not my graph, but it's popular. It's called the SMART graph, and it says you should have specific objectives, the progress of whom is measurable, that are actually determined to be achievable, are relevant to the goal, and can be done in a finite time frame. So this is a good way of looking at any operational plan, in my opinion. And what I want to talk about today is that there's I think Joe and his team have done an incredible job of getting adoption of the core principles. We saw a slide on how many different organizations have come together and said we need to have a learning health system, right? So that's sort of laying the foundation. The next step is operationalization. And so, and also I think we should discuss what practical historical knowledge can be shared today to learn from experience. I'll go into some of that later. And then I think one of the things in future meetings should be, of the dozen different approaches, what are the 2 to 3, based on dialogue, are the most likely to be successful and why? Whether it's public, shared, private, a composite, there should be a rationale, because you cannot, in my opinion, as a software entrepreneur, you cannot pick 10 parallel strategies, right? You have to pick 2, put your chips, on 2 maybe, perhaps, maximum of 3. And so I kind of laid out, I thought this was, the IOM has done some really good visioneering of what I see as a sequence of events that has to occur in order for us to create an operational plan. The first is we got to have a vision, and I think we've made tremendous progress on that and got stakeholder buy-in. However, it's important beyond the stakeholder buy-in to say who is going to define the precise vision and who will lead that effort. Then once that's identified, once the leadership is identified, the next question is, how do we actually acquire data? And here it's called a data utility, but the question is, what is the reason why entities will give data? Is it altruism, or is it legislation, or is it payment? Is there a payment business model that can be developed? The next question is very important, and that is how do we ensure the data is quality? Because if it's not high quality, either sufficiency and volume or integrity, then the learning health system won't work, the conclusions will be discarded, it may be abandoned, right? So we've got to have data quality. Then the fourth aspect is the systems engineering, which is how do we make systems actually talk to each other in a harmonious way that's fluid and automated. Doesn't require a one-off project for each question that has to be asked. And then the final topic is how do we validate the methodology and endorse the findings? And so these to me are the 5 high-level operational challenges. And if you look at the first one, which is visioning, I think we should propose, and again, we can't obviously do it today, but we should collectively propose who is the ideal leader of a learning health system, who is going to be best poised to ask hard questions, because hard questions can affect established interests. What's the best treatment, for example, for breast cancer? Is it, there are possibilities ranging from radiation to chemo to surgery, and everybody has an entrenched interest, right? So who's in the best position to be a neutral, trusted party, ask hard questions? What's the role of the government? For example, it can range from just being a funder to actually being a steward of the data, or even a legislator for data transfer, perhaps anonymously, or creating an option for anonymous information donor for beneficiaries such as Medicare and Medicaid that want to do it. Then even more so, another corollary question to this is, should the government function as a big data research body itself? Should it be actually, NASA, where it does everything itself, builds the rockets, mans the, the computers, and does everything, or should it just be a supplier of data, or should it be a creator of software? And I think that these questions, what I think is a good framework is to debate these and come to a consensus on 2 to 3 possibilities that are weighted by our best educated guess. And then what is a possible governing structure? So who should be on a governing board of such an entity? Is it a public-private? Is it a private nonprofit? Et cetera. And then finally, can the private sector, in combination with foundations, which is one of the things that I'm working on, create a learning health system without any government assistance at all, and even without government data? And so that's an important question, because again, I think we need to have a private and a parallel private and public strategy. So if you go to the next topic, which is how do we share data as utility? What are possible business models? Should the government actually pay for data, right? That is a possibility. Will the industry pay if they get something in return, perhaps on a pro rata basis? Will taxpayers finance data acquisition for the public good, for the learning health system, if they are enlightened? And I think one of the problems we've had to date is that most taxpayers don't understand what a learning health system means in terms of a tangible reality. And I think if we can reduce it to a tangible reality that's personalized, then that can create more demand for this to be created. The average patient that I talk to thinks we're already sharing medical records ubiquitously, right? Because they see the doctor pulling up their EMR on their iPhone. They're like, wow, my medical record must be portable. It's not. So we have an educational issue to overcome. And then there are questions like, eminent domain. I mean, I don't know if that's been tested before, but perhaps eminent domain of de-identified data for the public good is something that is possible. Where people can actually get paid for donating their data. And I think these are things worth debating. And then alternatively, there is a lot of data that's coming out now. It tends to be more statistically amortized, not at a high level of granularity, but it's starting to come. You know, data.gov is a government data source. CMS has provided some quality data. They've also provided some patient data. It does have significant limitations, like, you know, significant components of it are redacted. There's random anonymous data inserted to avoid re-identification, but there is precedent for government providing data. For example, in the United Kingdom, you can buy the actual granular level data on 11 million patients, which is phenomenal. So it's just not being used as a learning system, but maybe that same parallel can be done in the United States. And then there's also clearly public data sets that don't require a lot of data joining to have data on millions of people. The VA, the CMS, DOD databases, Medicare, Medicaid. And these are all available, I think, for scientific research today, even if we don't merge them and harmonize them, because each of these may have 10 million plus patients. So perhaps we should pick one of these as a starting point. Again, I think a realistic goal is to have a strategy for 2 to 3 options at most, but that's highly debated and rationalized. Then I think another set of important questions is what's the models for data sharing as a utility? And the key sentence here is current policies and financial incentives prevent data exchange even when it's technically feasible. So what I found in my previous company that I founded was that we could create harmonization standards and crosswalks and real-time translation between different data dictionaries. So the technology was not the problem. It was the business model. What do people get in exchange for providing data that is very, very hard to crack, and we should spend a significant amount of time on understanding the business model for data sharing. The third aspect was veracity and kinds of data. So in my opinion, it is very important for a learning health system to have individual transactional level data. So for example, a patient received a specific procedure, drug, diagnosis, or test on a specific date, as opposed to summary statistics only that can't be defended because there's no atomic level of granularity of what the patient actually had done or experienced. And so the question is, what kind of data is already expected to be available without additional effort? So you may have heard that the CMS has released to Medicare beneficiaries the ability to download all their transactions at the individual patient level. And that's a phenomenal start. And it's actually transactional level. So this is a significant crack, or not a crack, a significant breakthrough. It's just not being leveraged today. But it is for the first time where a beneficiary of Medicare or Medicaid can actually get their granular level transactional data of everything that's been done to them. Now it's one patient at a time, but it's been proven that there's data liquidity. So we should really, really debate, can this be expanded? And then other questions I said is, should information donors be a strategy? Should we try to legislate or advocate legislation of the option of information donation being a mandatory request at the point of care, if it's possible? And then, importantly, we should discuss, do online patient communities have sufficient scale, and can self-reported findings be helpful, or is that too early for prime time? The next slide is, how do we engineer the systems? And I think that this is actually the easiest part, in my opinion. I've done this kind of work before, and it is hard, but it's easier than defining the business models, right? So these things include syntax transport, terminological harmonization, But then the very practical things are, where should data reside? Should it be in the public-private consortium? Should it be in the government? Should it be in HHS? Should we create an entity like NASA to be the steward of this? Do additional laws need to be created to form these agencies? What kind of computational infrastructure will be required? If we're going to create a learning health system, we're going to need tens of millions of patients. Who will prioritize the questions that are to be asked? Should this be done in an open forum with the public involved? And then what technologies are required to query such large data sets on a continuous basis? And what is a realistic timeline to achieve this? The last slide I have is discussing how do we measure and articulate the effectiveness of our findings. In other words, are the findings meaningful, trustworthy, and translatable? This is a graph from the National Health Council. I borrowed it for this slide, but this is a report from 2014. I like the framework of the key principles of findings being, is it meaningful, is it trustworthy, is it translatable? And then the question is, how do we prioritize as a society the most important questions? Should it be medical specialty societies that prioritize questions? Should it be consumers that prioritize questions? Should it be policymakers that prioritize questions based on, for example, spending? What is the state of the present art? Will any of the systems that we have today allow for continuous automated direct head-to-head comparisons, which is true learning? Are the mathematical tools we have today sufficient? And I believe we need more mathematical tools for this type of mining. Finally, how do observational results get disseminated to practicing physicians? Because journals, for example, are going to be very slow. We need a real-time system. And then how do we get academia and specialty societies involved in publishing the results of the learning health system? If you look at the slide on the left, this is a very simple example of a way of visualizing